If you're building in healthcare right now, the single biggest bottleneck between you and your first enterprise contract isn't your tech, your team, or even your pilot data. It's whether the person running growth at a national payer believes your intervention actually causes the outcome you're claiming. Today's guest is that person, or more accurately, he was that person for nearly a decade at UnitedHealth. And now he sits on the other side of the table as president of Cityblock Health. Spun out of Alphabet's Sidewalk Labs in 2017, Cityblock has raised approximately $900 million in venture funding at around $5.7 billion valuation, with unbelievable investors, including SoftBank, Vision 2, which led to $400 million Series D, General Catalyst, which led to Series C, Tiger Global, and many more. Today, Cityblock is a value-based primary care company serving more than 100,000 Medicaid and dually eligible members across 7 states, partnering with 3 of the top 5 national Medicaid health plans. My guest today, Mike Roaldi, joined Cityblock as president in late 2024 to lead the company's next phase of growth. Before Cityblock, Mike spent nearly a decade at UnitedHealth Group in senior operating roles, most recently as Chief Growth Officer of United Healthcare Community and State. Before Cityblock, Mike spent nearly a decade at UnitedHealth Group in senior operating roles, most recently as Chief Growth Officer of United Healthcare Community and State. He's also a Notre Dame trained lawyer who started his career as a commercial litigator before pivoting into healthcare policy and operations. Mike is truly amazing, and I learned so much from this show. Get your notebooks out as we talk about so much when it comes to healthcare. Mike, it's amazing to have you on the show, so thank you for being here today.
Thank you, Vic. I'm looking forward to it.
There's a lot of kind of information going on right now, of how startups, specifically in, I guess, the AI world, are kind of working with, vendors overall. You spent a lot of time at United Health in your growth roles and so many different kind of sections. How do you advise a startup kind of building right now to pitch to vendors or pitch to insurance companies? And how is that looking like right now?
Yeah, the first thing I'd say is understand your value proposition in depth to them, to your specific audience, payer provider, but even the specific payer that you're working with. Talking to United Healthcare is different than talking to Centene or Molina or Kaiser, and they have different problems. And so to the extent that you can tailor your message specifically to a value proposition for them, that gets their attention a lot more quickly. The second thing, and this is one thing that I often saw startups make a mistake about, and that's that they didn't talk enough about execution. They talked about the strategy, the value proposition, but they did not demonstrate that they could actually deliver. So disciplined execution, which is difficult to convey in a short pitch, but you can detect it when you're on the buying side. Are they showing me workflows? Are they showing me they know what challenges startups in this space often face and how they've overcome them? That brings a lot of credibility. I'd also add one thing not to do, and this is going to sound a little bit contrarian and maybe even a little bit cold, but I would not start with your why the way often startups are traditionally coached to. And the reason for that is I think everybody now knows that that's what startups are coached to do. That's what many of the pitches follow. Once you've seen a lot of them, they follow a certain template. And once you've heard enough of them, that upfront story of why doesn't quite have the power of that it did, when people first started using that template. So I would let that, it's not that you shouldn't talk about why, what inspired you to get in this place, but I would let it come out more naturally and not be the centerpiece of a presentation the way you often see it. Just doesn't have the same sincerity as if it comes out naturally as part of your presentation, as opposed to being so central or upfront.
Right. Is that because like you kind of want to know the person when you know the product, what they're building is very interesting, and then kind of over time as they're kind of pitching you the product or kind of talking about it, you kind of learn more into what it is, why they got into it naturally. I mean, is it just more of that natural progression instead of kind of going into it in an emotion basis? Like, what is the reason behind
I think
that?
it's authenticity, honestly. There's two things. One is you have a limited amount of time as the buyer,
Yeah.
the payer or provider that's listening to the pitch, and you want to quickly assess whether or not it's something you're going to seriously consider. And, sometimes you want want to hear why it's relevant to you quickly. But then the second is, it's more authentic uh, and and more persuasive when you hear that somebody has started a company because of something personal that happened to them, when it comes out naturally as part of a conversation instead of being the first slide in a pitch deck.
So, are there any specific things that you're looking for in the first meeting or even the second meeting as the meetings progresses? What are the things that you're looking for, and how does that change over time?
Yeah, ability to execute and value are the two major things. So maybe I'll just go. I know I said that already, so maybe I'll just go a click deeper on each of them. On ability to execute, I want to understand what metrics you are going to track, but I also want to understand how you've engineered the solution to get to those or achieve those metrics. So the staffing, if trying to think of an example, but if it's your tech solution, the staffing, the means of
Yeah.
outreach, how you've tackled the hardest problem that you face in whatever value proposition that you're putting forward. So if it's an engagement strategy, how have you overcome having bad contact information? How do you track not just the number of people you engage, but the quality of that engagement? And then where you have delivered it so far. So execution with a specific emphasis on reporting and monitoring, but also how you've overcome the most challenging problems for a startup in that space. And then, in terms of value proposition, I would not leave it at we can improve quality, or we can reduce the total cost of care, or we can, improve your relationship with a client. It's the more specific you can be. We have had this success with controlling high blood pressure or a follow-up after hospitalization HEDIS measure. So that's where it becomes much more credible and compelling. If you're just saying we improve HEDIS scores or we improve readmissions, it's difficult to know what level of impact your particular solution has had on that thing.
That's exactly like the common ROIs that I kind of see a lot of startups pitching now are I'll improve your HEDIS, your decrease your ED visits, or all of this kind of common stuff. And I wanted to, and I think you touch exactly where it is. Like, are there any ROI kind of unlocks that are beginning to become new that you're seeing that's like that's interesting. This company is kind of saying they can do this for us, and this is a big problem that we have. Is that something that you're seeing right now, or is it just the common stuff and making sure that it's actually presentable and that's something that you're actually kind of solving?
I think the more effective vendors and startups are able to get more granular with what they're impacting instead of as I said, instead of a HEDIS in general, particular measure, med adherence, or pick your HEDIS measure that you think you can impact. Follow up after hospitalization and behavioral health is often a very difficult measure to move. So that's one thing. In the big traditional heuristics, quality improvement, total cost of care, just being more specific with respect to the things you believe you're going to impact. And then there's a few emerging categories that I think folks should be aware of. Can you impact unit cost for a payer or a at-risk provider because you're able to engage members and make sure that they know there's other options available to them, or different sites of service where the quality of care is the same, but there's significant difference in the unit cost? Can you show that that the payer can reduce its own administrative costs because you're going to perform a function for them that they're required to perform, but no longer have to because you're able to do that? So there's the traditional categories, I would say, get more specific and get more granular. And then there's a few other categories that people don't often explore. Like, can we impact specialty referrals that really can be handled by primary care? Can we get people to a more appropriate site of service that they prefer and is lower unit costs? Can we help reduce the payer's administrative costs by performing required functions? So I think that's the level you need to be thinking at. I think many buyers have seen the traditional high level categories many times and become somewhat skeptical.
And From the opposite side, though, from the buyer side, is there anything the buyers should be doing or changing from their perspective when evaluating a lot of these AI tools right now? If they have like a fixed mind on something specifically and they should be changing how something should be done?
There's a lot that should change on the buyer side. Think that one mistake that people make when they're pitching large organizations is that they assume that they are homogenous or speak with one voice, one opinion. And so when in fact you could have a very successful pitch, sell even a very senior person on the phone, and that person is incapable of, is not able to get their organization to actually finalize a contract with your company. So if I could say one thing that the payers, providers, buyers should work on, it's cohesion around decision making, because there's often instances in which things clearly present a strong value proposition, but the buyer can't get out of its own way to get a contract done for a lot of different reasons. So I actually, I know that's not necessarily where you were taking your question. I think you're kind of looking at, should the buyers reassess the value that these solutions can provide? And there's truth to that, but I actually think many of them recognize the potential value, and they struggle with navigating the organization from legal to finance
Mm.
to other business leaders that prefer a different vendor, and that really creates a lot of inertia.
Sorry, I'm a little bit naive on the whole, like when it comes to like insurance, don't they have their own kind of finance lawyers to kind of take a specific, vendor that they're evaluating and kind of send them to the finance teams or send them to the legal teams to kind of get that qualified and see if this is the best potential option and then kind of come in and make a joint evaluation at the end? Is that how the process kind of looks overall? Because, we always see the large kind of sales cycles and payers as well. So how does that whole process work when they're evaluating the whole, I guess, vendor?
I can speak more to the payer side. There is not one legal team. There's many. There's privacy, there's business legal, there's sometimes network legal. Similarly, distributed finance from actuarial team to the FP&A function. So I don't think many have as streamlined of a process as you just outlined, which is why sometimes I'm sure many vendors that might listen to this or who you've talked to have felt like they're very close to getting a contract signed with a payer, and out of nowhere it goes cold.
Yeah, happens a lot.
And oftentimes that's another business leader, so maybe a local P&L owner and a national P&L owner, or another, the privacy legal team comes in and says, I have concerns about the data that we're going to share with this organization. Or the network team says, we have certain certain cost savings targets that we're not able to hit because you're signing this deal and it's accounted for differently. So it's that heterogeneity that makes it really challenging, and sometimes gives folks a bit of whiplash because they feel like they've built this great relationship with the business leaders. The business leaders are bought in, they're senior in the company, but they then have to go oftentimes sell it internally across these different teams that may have their own sets of incentives and concerns.
Or is that process like I guess for the payers when it comes to getting like from the finance team or for compliance saying, oh, we're kind of nervous or scared about the data. How can, I guess, companies, is there anything that they can change, the vendor specifically, they can change on their end to, I guess, give them best kind of transparency or best flow? Is there any discrepancies upon, depending on that as well?
Be patient, because you'll burn your business champion if you're too pushy, honestly, because they're probably trying to help. They're probably trying to, just as frustrated as you are. I know that's not an answer that's people want to hear, but I think patience does help. Yeah. Second is, be very responsive. When you get a request, turn it around quickly. If it's a duplicate request, like you just sent that same thing 3 weeks ago and they're asking for it again, politely point out that you've already provided it, but provide it again. And I think be as clean and as tight, because every cycle, every time they have to ask for something new, if you've made it an error in what you're sending over, that just might be another 2 weeks before you can get on the phone and clarify whatever the problem was. So just I guess it's just to execute the basics well, be responsive, have good information, don't have to clean up information that you sent back over, and just be overall give the give the clear impression of being a mature and professionalized organization.
And we kind of touched upon this in the beginning when we were talking about the ROI heuristics, but I bet you specifically when you were at United, you got so many email outreaches. How did it look like when you were going through them, or you saw, oh, this one looks interesting versus the other? Was there any specific email heading, email title that kind of stood out when it came to the specific ROIs that they're mentioning? Like, what made some vendor stick out versus another?
I'll be honest, I never responded to a cold email outreach. I can't speak for other senior leaders at other large organizations, but I don't believe that I've ever I shouldn't say that. If there's some personal connection, if it's, I went to your alma mater, you know, "Hey, can you do me a favor and meet with me? I know a friend of yours," then as a courtesy, I would try to take the meeting. But without that personal touch, I don't think that I've ever, no matter how compelling the ROI in the subject line or the first sentence of the email is, just was never inclined to respond and take that meeting. Again, other senior leaders might be more open to that, but my advice would be to try to find some sort of personal connection. And then, when you do get a chance to talk about the ROI, talk about it in the ways that I was discussing earlier with being much more specific and not falling into those categories that everybody talks about, but maybe being a click deeper on those specific HEDIS measures, you know, uh, you know, different levers within the total cost of care.
I'm curious, is that the biggest problem that you see in like decks when you're officially finally presented with the vendor? You see their deck, and it's mostly, as you mentioned, the why, which is the biggest. Okay, well, I'm seeing this a lot. But they're not going that deep into the actual, ROI impacts of what they're doing, what they have done. Is that kind of a red flag to you overall when they can't really display that without a meeting? Or is there what in the kind of deck as well kind of compels you, okay, this is very interesting and kind of can potentially help our members overall?
Yeah, I mean, I think it's the granularity with respect to the outcome and then execution. And I've hit this point a couple of times, so maybe I'll try to do it by analogy.
Yeah.
If I it's kind of like showing your work. I have a 13-year-old, and when he comes home and tries to do his math homework, I can sometimes give him the answer off the top of my head. It's getting harder as he gets older, honestly. It's getting a little bit past my skill level. But the teacher's going to look at that and say, I have no faith that you've learned this or understand it just because you have the answer correct. I want to see how you got there. I mean, if you ask someone, you can detect this sometimes, I think, when you're talking to people about, something that might have a technical component. If I ask somebody at the bike store how my bike was fixed and they say they fixed the gear wheel, that person probably didn't fix the bike. If they say, well, I took apart these 4 specific components and then I reconstituted them in this order, then you're like, this is the person that knows how to do this, and I would have faith in them to do it again in the future. And so, it's difficult because you only have so much time. But I would say if you're selling a kidney care solution, you should be able to talk about the hardest parts about treating somebody with ESRD or CKD and how you as a company struggled with that at first and then broke it down into its components and then built a solution around that. Or in some cases, you weren't very good at it at first, but then you made this small improvement and this small improvement and this small improvement. And cumulatively, you've suddenly gotten much better at this very difficult thing. And so the best pitches are the ones that can have mastered that can convey that level of sophistication and understanding without, droning on forever.
Going into a little bit of your kind of background here, you started off as a litigator and then obviously went to UnitedHealth. Was there anything from your litigation time as a commercial litigator that you took away that actually helped at United? And did that jump kind of actually give you a competitive advantage versus maybe other people, you think?
Yes. The first thing is an understanding of regulatory schema, the way that the way that statutory and statutory law and federal regulations work together to frame the business reality that we all live in. So that's first and foremost,
Right.
just being able to understand, what regulators have what scope and how we have to live with that as a business. But I'd take it a little bit more personal. What litigators have to do is, especially commercial business litigators, is learn enough about a business to interact with experts in that business and draw out what is factually relevant to a case. So, I had cases from banking to the energy industry. And if you're going to depose an executive of an oil company or take a deposition about whether or not a litigation surrounding a transaction, even if they violated labor laws, you have to understand their business well enough to ask them intelligent questions about it and get facts that are important to the case. And so that means you have to delve into a business that is entirely new to you, read about it in depth, speak to experts about it enough to educate yourself to have an intelligent conversation with somebody who's been in that industry for 20 years. And so I found that to be a very helpful skill as I learn a new Medicaid market or work with a new payer or try to understand a new federal risk adjustment scheme so that you can quickly read up enough to know that you have gotten intelligent and can make strategic decisions. I think I learned that from the law, a lot like consulting, where you just have to go from business to business and learn it well enough to make intelligent decisions.
And when you were at United, you had to work with a lot of providers. And what did you, I mean, kind of going into to United, I'm assuming you had some type of conception of what it would be like to work with different players in the ecosystem, what to evaluate for different, obviously, vendors, but obviously for providers as well. Are they meeting the benchmark? What did you misunderstand at first that you were like, oh, dang, that's completely wrong? And then I should have thought something else. Like, did that change thought process change over time?
I did not fully appreciate the diversity uh in the in provider community in the network of healthcare providers. I think the first time I walked into an FQHC, it looks a lot, well, it depends on the FQHC, but oftentimes it looks and feels a lot differently than your average primary care practice. And so the challenges that I thought of providers are providers, but by actually getting out into the field and interacting directly with providers in their offices, hearing feedback from them, just the significant diversity in the challenges that they face based on the population, based on the type of care that they're delivering, wasn't something that I appreciated before working at United and getting out and doing that. I also did not appreciate the level of administrative complexity that they deal with. So I give an example. I was speaking to a billing specialist at an FQHC who said, when I go to bill a plan, I can't just pick the name of the plan and then submit the bill, but I have to understand, is this their DSNP member? Is it an MA member? Is it the Medicaid commercial? I have to understand whether sometimes they have two plans. I have to understand whether that particular service is covered by that plan or that plan. So just it's well documented, but the administrative complexity that providers have to deal with was a surprise to me.
Yeah, I'm not even surprised. That's definitely something like, even like if you understand it going in, you're probably going to be mostly surprised when you're kind of dealing about how complex it is. But when you started off, though, you kind of were working a lot in the social determinants of health, kind of figuring out how that can work and relaying that to multiple different provider systems. What did you learn from that? I'm very curious because we still see now the concept of the holistic health approach, which I'm really intrigued to kind of know how that looked on your end when you were at the payer side. It's what did you have to do with the providers? And I know it had to be harder than you thought, kind of balancing holistic health, but what was your process like for that?
We initially took the approach that we were going to set up a network of social services providers similar to our provider network, which was an approach several took at the time. I won't name the companies, but I think many are familiar with the kind of community resource finder function. Uh, And I learned two things about that. One was that the providers, especially FQHCs who had high needs populations, had been doing that for decades. They had been doing it informally in like binders in their offices. I'll never forget being in Kalihi Palama Health Center in Honolulu. First, they told me they had 26 different languages spoken at that FQHC. And second, we came in and said, hey, we can have this electronic system where you can refer out to social services providers. And they pulled out the binder that was, here's who we have been referring to for years. And we know when they have capacity, we have relationships with those people. So the first thing was that providers had been doing this informally, especially providers for underserved communities had been doing it informally for years. It wasn't as novel as we thought it was. And then the second was that it has to be connected to the way that those services are funded. I also sat with a lot of community-based organizations that we were trying to get in this network of social services providers, the Goodwills of the world who do job placement and housing support agencies. And what I quickly learned was that many of their services were tied to a grant. The eligibility didn't line up with Medicaid. So by just referring somebody from a primary care clinic or a Medicaid member of ours into their services, they weren't necessarily going to get paid for that member. And so it just strained their capacity in a way that wasn't helpful. So the takeaway for me for that was we need fully integrated providers that can do many of those things. And where they need to refer out, they have localized relationships. You can digitize it, but the equivalent of the binder that wasn't just a list of providers, but also provided that local knowledge of who can actually help with these types of things. And that's really what Cityblock does. I think one of the reasons we're so effective, that localized knowledge.
Yeah, that's exactly amazing transition because I wanted to kind of learn when you were at Cityblock, or still at Cityblock, you kind of talked about how if you had to design a provider like how Cityblock did, it would be like how Cityblock did. Like Cityblock did it amazingly well. What were the specific choices that you saw that Cityblock has made over time that kind of one attracted you to Cityblock, and then two, kind of something that you recommend other kind of vendors or health partners be doing in that same approach?
Yeah, the first is we invested a great deal in proactive engagement. And I've talked about this before, but we spent a lot of time understanding and developing our ability to reach members and make those kind of incremental improvements that I was talking about. Oh, if we send a mailer before we call, are we more likely, 5% more likely to get a response from that member? What do the wording of the text have to be? What types of things do we offer? So the first thing is just engagement, investing heavily in engagement, proactive engagement, because traditionally that's not, your old fashioned brick and mortar primary care practice doesn't have the capacity to do that. So first is investing in engagement. Second, I would say, was coordinating with other providers. And certainly this is something that some other providers do. We've really made it part of our core competency. We call it a wrap provider, meaning we will take on membership that already has a primary care physician, and we will offer them traditional primary care services ourselves, even though they have another primary care provider, because we are able to layer on additional things that traditional brick and mortar primary care provider isn't. But that requires our ability to talk to and coordinate with that primary care provider. It's true in specialty as well. Incredibly important for us to be able to talk to, share information with, and coordinate with the other people, other providers giving care to our members. So proactive engagement, coordination with other providers, and then last, just a decentralized model, not so attached to a clinic, even though we do have clinics. And then going forward, it's really leaning into AI, which everybody is saying, I think we're executing on better than anybody else. That ability to reduce provider administrative time, but also have member-facing agents that are interacting with members and delivering really excellent customer service for those patients that need help and call in to Cityblock.
Yeah, when it comes to engagement, I wanted to kind of double click on that because, when it comes to working with these payers that you guys are working with, which is a lot. How has it kind of changed over time with the engagement? And you kind of were harping on this. I'm assuming at the beginning it was very, not that good as what you guys were hoping, and then it kind of improved so much better over time. But what was the, I guess, payers also interaction, or I guess not interaction, but like their thought process when seeing the ROI that you guys kind of thought Cityblock would be giving, but at first it wasn't? Like, how did you guys change that?
The strength of our partnerships is based very much on transparency. Obviously, having sat on the payer side, I interacted with a lot of value-based providers, and they were not either not capable or not willing to share a lot of data on their performance. Obviously, we could see claims data, but their operational performance data. So we are able to show not just how many members we reached, but how many members we reached and enrolled in our pregnancy care pathway or our diabetes care pathway or behavioral health care pathway, how many members we reached and longitudinally engaged, how many members we reached and closed each specific quality gap with. So we don't just stop at engagement, we show engagement in particular services. And I think, I don't know, to some degree, I challenge the premise of your question. I don't know that there was ever a time where we weren't seeing some results from our activity, but where we may have had some challenges early on in relationships, we could show this is going to come. We're going to see impact, and we have confidence that we're going to see impact even though we're not seeing it now, because our leading indicators of impact were lining up. We are engaging this membership. We are enrolling them in these programs. And so maybe there's a little bit more lag than we anticipated in seeing that impact. But that really helped keep the relationship strong, even where we might have had challenges with.
Yeah, if I had to pick, I felt like the lag would be the biggest kind of thing at first. It's because, it's like we need to start getting everything going, and we have to show, as you mentioned, the transparency is the biggest thing, and kind of prove this is exactly what we're going to be doing and kind of get it done as soon as possible. But, you guys kind of worked a lot with, you guys work a lot with a lot of different organizations. Virtually, you have providers working in home, community based clinics. But something that's really cool, I didn't really know until I was doing my research, was that you guys have care teams with paramedics. Can you kind of talk about any instances that where, because of your team of paramedics, they went into patient homes for right, like emergency kind of needs, how it kind of helped save a patient's life, or something very like super obviously like important and vital like that? Is there any specific examples that you could share?
Yeah, what you're referring to is our mobile integrated care team.
Yeah.
I'm sure there are many examples of meeting an urgent or emergent need from that team. None jump out off the top of my head, but one thing I'll point out is how much of a positive impact that has on independent living for our members who have, significant chronic conditions or may struggle with activities of daily living. What I often, when talking to members, have heard is that knowing that they have access to that service where somebody can be in home quickly and deliver medication um or have a combined visit with a provider virtually, then actually administer or do a physical exam, knowing that they have that access to that type of service makes them feel a lot better about continuing to live in their home where, they might otherwise have to be in a nursing facility, and I know there's been a number of instances in which, members have an acute health event that our team has been able to get there and help. No specific stories jump to mind off the top of my head.
Yeah, I mean, in the unit economics of this whole like thing that you guys built, how does it work at scale, and what do you guys kind of get wrong at first? Because it's a huge kind of undertaking, right? Of kind of working a lot in virtual, in person, having these community-based clinics, and then having all of this paramedic, all of this kind of going hand in hand. How did it work, kind of scaling?
We, I think, did a lot of testing with respect to what the most important services were for our members, and, didn't have that designed perfectly at first. And
Yeah.
so we probably invested in having some capabilities that weren't as impactful to our membership as we expected.
Right.
So that's one thing. And so ensuring that we have our cost of care in a place that's sustainable is important, and that requires making sure that we're investing in the services that are most important to members. And so that comes with scale. That sort of learning comes with scale. One other thing, we have a pretty diverse set of members, patients. Some are duly eligible members with very rich benefits, LTSS benefits. Others are what we would call TANF members or just general Medicaid members. And so being able to centralize our services so that we have certain standard core capabilities that we deploy against every market, like our ability to engage members. We have to do that regardless of what the membership profile is in a market. But then being able to deploy those care pathways that are most relevant to that group in that market. Our Massachusetts market, we have a lot of members that are dually eligible members. Uh, um, they're eligible for Medicare and Medicaid, whereas our North Carolina market, there's a lot of moms and kids in that population. And so what is common and what can we centralize versus what is necessary to tailor specifically to that population? That's been a huge unlock for us.
What specific markets were kind of, I guess, lagging at first, and then you guys saw like a quick upcline or up change over time, and now it's kind of like pretty much a very active market using Cityblock.
You mean in terms of our footprint in
Yes.
that market?
Yeah. Yeah. In your footprint. Yeah.
Yeah, we've grown quite a bit in Ohio. We were written into an RFP there in 2020. And thanks to, I think, our effective delivery of services, the strength of our operation there, we've gone from, a single contract and a single population to several contracts across the kind of spectrum of Medicaid and Medicare in the state. So that's been a great success story for us. And one that's really built on our ability to demonstrate that we can deliver there.
Yeah. For founders kind of listening in and they're kind of building a care delivery company, which a lot of are, what is like one design decision that they should create in month one when it comes to execution and kind of save for by the time they get to month three, month four? What does that look like?
I have two pieces of advice. One is directly relevant to your question. One is just maybe free extra advice. First is hire someone from the industry. I think the ability to talk intelligently about the value proposition sort of depends on having an industry insider. So, if the founder themselves is not somebody who worked in the industry that they're selling into, having somebody as part of the senior team that is I think gives a lot of credibility and helps quite a bit. Second is get your data infrastructure right early, if you can invest in a CTO. But I've seen so many instances of downstream impacts, clunkiness, inability to inform operations effectively, where legacy systems are put in place and then before you know it, they're so embedded that it would be incredibly painful and expensive to institute a new system, move to a new vendor. And so you spend a lot of time thinking about what scale will look like with the data infrastructure that you're investing in. And again, it might require having a CTO to think through that in the level of depth necessary to make good decisions early on.
Do you recommend a CTO that has that medical background, healthcare background, or can someone that comes in with massive AI knowledge come in and kind of build this out? Does there need to be some experience in the healthcare world? Like, can you suffice with a really good CTO that knows how to build with a great clinical advisory team that can kind of help you along the way? Is that something that can work?
I struggle with this question because I would have had one answer a year ago, and then we hired a CTO that did not have industry experience, and he's been excellent and learned the business very quickly. So a year ago, I would have told you that that's almost impossible because healthcare is so nuanced and not intuitive. The safer bet is to take somebody from the industry because there's a lot of risk if the person that you hire is not willing to invest in the knowledge to be effective. But maybe the highest ceiling is if you bring somebody in from a different industry, understand consumer preferences, maybe can bring a new way of thinking, but is willing to invest and learn the healthcare system as well. So the cop out answer I'll give you is it depends on the person.
Cityblock specifically, though, has kind of works a lot with a lot of Medicaid plans. I guess 3 out of 5, multiple different states. In the Great Sunshine State of Florida, New York, anywhere. Can you walk me through like how you guys present a potential partnership with one of these plans and how it kind of goes from start to finish? How does that look?
Now at this stage, because I think our
I bet now
we
it's a little bit easier.
yeah. Yeah, we're pretty well known at this point, and I
Yeah.
think we've had enough success that we have a lot of inbound, honestly. Folks that, want to see innovation and know that we have a consistent track record of delivering it and want to move to more value-based care. And so we really do have a lot of inbound, which is exciting and definitely makes our lives easier. We also have grown with our existing clients in many markets, which
Mhm.
is, again, I think a sign of the strength of our operation and the value that we're providing. So with 2 plans, we now are in 4 states. One plan, we're in 3 states. So we have that organic growth with existing clients, and we have a lot of inbound thanks to the I like to think thanks to the value that we've delivered. But, as we're looking for new clients, I think in addition to the many things that I talked about earlier about pitching, we try to make ourselves easy to work with. I think, one way to get over that complexity of working with a payer is to really strip down what's your PADU, what are the things that you absolutely need in a contract versus things that are nice to have so that you're not going back and forth fighting over terms that aren't critical, and also sharing data back and forth with the provider or the payer so that they know what to expect from you, having joint operating committee meetings to give
Yeah.
the transparency into your performance. So in addition to the delivering on the granular value drivers, I think we like to think that we're easy to work with.
You mentioned this a little bit ago about one of the biggest top cost drivers for insurance is LTSS. And that's something that is really crucial, and you kind of drove that a lot. Cityblock, can you explain what that is, and why you decided not to kind of move fast when implementing this specifically, and how it looks overall?
LTSS is long-term services and supports. So it's a category of benefit in Medicaid that only certain members qualify for. And they are members typically who have certain activities of daily living that they're restricted in. So usually there's an assessment done to determine if this member has trouble with these activities of daily living. It could be getting around the house, it could be cooking, it could be using the restroom. So if members after an assessment are determined to have some limitations on those activities of daily living, they qualify for long-term services and supports benefits in some
Yeah.
states. That can be often somebody in their home that helps carry them, from the bathroom or from their bed to the restroom. It could be somebody who helps cook and clean, lots of different help for members that fit that category. It could also be home modification, so a bar in the shower to help them get up and down. It could be durable medical equipment, a electronic wheelchair. So it's those things that are not traditional medical benefits but have an impact on people's health. And so what we have done, we didn't initially, I think, make this one of our core capabilities, partially because it's so important to get it right for those members. If you get LTSS benefits wrong and the delivery of LTSS benefits wrong, these are the most vulnerable members, the members that need
Right.
the most support. If you say we can do that as a company, as a startup, and you don't deliver on that promise, it has a huge impact on those people's lives. So we wanted to make sure we had confidence as a company, as part of our mission, that we were going to do this well if we were going to do it. And we reached that level of confidence. And I would say it's very rare for those LTSS benefits to be coordinated with a member's primary care. because it's a different set of providers. We are able to do that, which is unique and I think provides a remarkable value to members. So there are primary care physicians that are interacting with those members can see not just how are you managing your diabetes, what are your underlying medical conditions, the state of your underlying medical conditions, but they can talk to that LTSS care manager and say, this person needs some additional support in their home. They've shared that, they've slipped getting out of the shower 3 or 4 times. So that integration is just, I think, really unique and potentially impactful.
In I guess now from 2025 2026, we saw a lot of changes in, I guess, federal budget pressures and a lot of potential cuts potentially coming. How can an early stage founder, I guess, kind of tackle their present business models that they're kind of doing, I guess, pressure testing that with clinics and other potentially champions that they're looking for? How can they use that into the best capability and find out what works and what doesn't?
The uh, the having a function or a team that is its purpose is to monitor the policy changes
Yeah.
is very, very helpful. That's probably a lot to invest in at early stage, but there are a lot of good policy consulting agencies out there that do this as part of their core competency that you could probably have a contract with them to regularly check in and understand what is likely to pass and what the downstream impacts are. I would say always start with the financial impact. The big changes over the last several years have been to the methodology for risk adjustment in Medicare and then eligibility in Medicaid. As we're seeing the one big beautiful bill requirements phase in, a lot of those members are going to need to show that they're working or looking for a job in order to stay eligible. That's going to have an impact on the plans. Are you helping them solve that new need that they may not have built the capability for? Obviously, V28 and the recent rate notice, ongoing evolution of the risk adjustment model in Medicare. So understanding those nuances and knowing if you can help solve what might be a gap for the whoever your client base is really important.
Couple more questions before we go to a quick rapid fire here is, you mentioned you guys are using AI. You guys are in the forefront of AI. And how does that look like right now for you guys? Where are you guys implementing it? Where has a lot of members said, oh my goodness, this is amazing, lifesaver because of AI? Like, where has it been very useful? Potentially, if you guys have seen a use case so far where it potentially hasn't been useful, where you guys spent so much potentially finance on this specific kind of AI capabilities, but no one even used it, or it was something that had a terrible ROI.
Yeah, we break it down in terms of member journey. So very upstream, we're using it for population health analytics. So um the traditional risk stratification model is low risk, emerging risk, high risk. And that was algorithmic. So you would say, this person doesn't have any chronic conditions and they're engaged with a primary care physician. They're probably low risk, but it's essentially just a series of if then statements. Whereas
Yeah.
high risk, recent inpatient event, acute condition, no engagement with primary care, something like that. Now we're doing individualized risk profiling for every member. And AI makes that possible in a way that the traditional risk stratifications couldn't. So, teaching the AI tool based on our extensive data set of underserved members, which is unique to us, not just their medical and claims information, but the record of our interaction with them and what produces meaningful engagement to create a specific engagement strategy for each member. So that's the first category, sort of like very far upstream population health analytics, stratification, individualized risk profiles and outreach strategies. Second category is pre-visits. What can we help our physicians, our clinical teams with so that they reduce the administrative time necessary in order to really understand what's going on with this patient. The third is in the direct interaction with members, so ambient listening tools, also auto population of assessments so that provider or community health partner can be more conversational with the member and doesn't have to tick through a series of questions. Also, we now are using inbound call agents that actually have the direct interaction with the member so that they can route them appropriately to the right type of care, escalate when necessary, answer basic questions. That's been fascinating to listen to on the agent is remarkably capable of fielding complex questions and getting patients the answer that they want, and then post visit follow up. Reducing the clinician's documentation burden. Some cases, text follow up, voicemail follow up. So it's really like embedded within the entire care journey. And I think because we're at that direct point of care with this unique population, we are developing capabilities that it would be very difficult for anybody else to develop.
Yeah, and when you guys kind of, for example, you said ambient listening and things. Do you guys work with a lot of third party tools like a Bridge, for example, for that, or do you guys build your own in house kind of tools for that?
We build our own, yeah, based on because we think our population is unique. We want to make sure that it's customized and uh, it's it's taught based on our patient population.
Back a little bit into the United days, you mentioned one big thing. I mean, not you mentioned, but you worked with a lot of patients that frankly don't really trust the insurance population at all, right? It's the least one of the most least trusted, you know, health parts of the healthcare system, as well as pharma, big pharma. So in that space case specifically at Cityblock, I mean, I kind of want to hear two of your kind of approaches here. The first one is at United, how did you kind of see this unfold? Like, how do you think patients should have seen another light of how insurance payers should be kind of looked at, and maybe it's not marketed well or used well? And then how does that translate to your days at Cityblock and kind of building that trust? Maybe there was kind of like lessons from United that you take to Cityblock.
The unlock for me when I got to City Block, and I wish I had come to this insight in my payer days, but people trust you if you are providing them value and not trying to get something from them. So our first interaction with members, there's an instinct from both payers and providers for your first interaction with a member to be an attempt to close a quality gap or an attempt to do an assessment that you have some incentive to do. And so there's often you actually get the member on the phone, you want to make sure that you check this box with them. At City Block, we take a very different approach. When we have contact with a member, either in person or on the phone, the first thing that we try to do is give them something of value that's appropriate so that we understand what their biggest need is now. And going forward, then they see us as somebody that can help them, as opposed to somebody that's another group that's calling to try to get them to do something. But if we find out, hey, they haven't had a healthy meal in a week and they've been eating fast food, and we can get them a food box, that solves a problem for them, and they are appreciative and therefore have earned more trust that should translate into the relationship going forward.
Yeah, and now quick rapid fire here, Mike. Are you ready?
Yep.
Yeah. So where do you see City Block in 3 years? And specific key milestones, I guess, for national growth.
I'd like to be in 20 markets in 20 states in 3 years. And I'd like to have that member journey be infused with AI across those stages that I talked about earlier.
Yeah. Quick question on that. With AI specifically, how have you seen members interacting with AI a lot? Has there been a lot of, just opening up a lot of simply ChatGPT and asking a lot of medical questions? How have you seen a lot of these guys maybe utilizing your tools, using AI overall, specifically on the member side?
A lot of ways, but one interesting thing that I'll highlight, what I've heard a lot of is where a member is confused by the healthcare system in general, which of course happens all the time, happens to everyone, but probably happens more to underserved populations like City Block serves. Um, they, uh, I've had the privilege of listening to several calls with agents where the member calls in with a high level of frustration and confusion, and the agent is able to talk through one, approach the member with compassion and patience in a way that honestly a human call center agent might not, and then also sift through the issues that are causing that member's confusion, give them answers, and if necessary refer them to the right provider within City Block system. So I think one of the reasons that we have such a problem with certain populations not being able to access care is just confusion. And so I'm really excited about this sort of navigational capability that our AI agents have been able to develop, in addition to just, responding with compassion and patience.
Yeah, I mean, what is the biggest myth about serving high-speed Medicaid and dually eligible members that that pretty much kind of like gets destroyed over time? Like, what is the biggest myth over there?
There's a persistent myth that that population is not digitally connected, and that is, statistically not true. I shouldn't say that. There are certain subsets, rural areas, especially where, broadband connectivity is still challenging. But in general, there is, where they're where they reside is there's connectivity available. Most of them are digitally connected and do benefit from digital care because of many of the social challenges that they faced to get to brick and mortar care, like
Yeah.
transportation. So I think I found that myth. We still get questions like, "Do these people have smartphones?" Yes, yeah, for the most part they do, and they do have connectivity, with the exception of those rural areas.
Yeah. Yeah, and what is the toughest lesson you've learned from moving from United to Cityblock?
Patience, I think, with the um the difference in resources. The At a place like United, the industry is trying to catch up with you or chase you, whereas when you're at a provider that's developing relationships and selling into the payers, oftentimes you're more in a responsive position to those trends. So kind of patience with the way that different trends emerge within the industry and our ability to respond to them.
Yeah. Final question: how do you balance family and personal life and work life? I know you mentioned you have a 11-year-old boy. How do you balance all of this? I know you're super busy. How does it work?
I focus a lot on the quality of the time that I'm with my family. And so when I am with them, I make a point to disconnect as much as I can. And I also try to find those activities that they really enjoy that we can bond over. So I'm coach of my son's baseball team and flag football team, probably a little too competitive in the when I'm the coach. But it really gives us a chance to be together in with more time, but then focused on a thing together, not distracted by work, taking calls and logging onto my computer.
I bet it's a lot of weekends of just screaming, like you're losing your voice a lot. I mean, yeah, I'm curious. So, like, I'm assuming your son maybe comes and says, "Hey, I lost. I lost. I'm sad. I lost." Like, how? What is your best way of kind of coming out and saying it's okay? You have next game, or like you have this next opportunity. Like, what is your biggest advice for just saying it's okay? What happened now, but you can always come back later.
Yeah, I have a lot of experience with this because I was born in Buffalo, New York, and I'm a Buffalo Bills fan. And if you don't know, they're historic,
Oh,
tragic, just a history of the most painful, excruciating losses
I feel
in
bad for you
sports
guys.
history. Yeah, and so I made the mistake of making my kids Bills fans too, and they all have to live with it now. So we actually talk a lot about the lessons that come from losing, and it's the classic cliche: you win or you learn. My father was in sales, and he was big on that. The pitches that you do, if you didn't sell it, you learn something. And so we talk a lot about that. If my son strikes out, take that moment as an opportunity to get slightly better. Every practice, I ask the team to think of one thing they could have done better that day. So I love sports for that reason. Just constant lessons from failure. Failing doesn't mean you're a failure, you know. So I try to instill that, and then there's always next year for the Bills.
Hopefully. It's like becoming the Cowboys at this point. It's not that bad, not that bad. But dude, it's amazing to have you on the show, and I enjoyed this so much. It was a pure joy to have you, and thank you so much. I truly appreciated this.
Likewise, I enjoyed it. Thank you.